Hi, this is Dr. A with your fifth and last video on healthcare financing, which is Chapter 9 of the 5th edition of Basics of the U.S. Healthcare System for our Intro to U.S. Healthcare class. And so we are going to look at miscellaneous topics. So reimbursement methods of private health insurance. So the federal government has developed various mechanisms aimed at standardizing reimbursement for healthcare services. So in response, the insurance companies developed their standards for usual, customary, and reasonable services based on community and state surveys of provider charges. So usually is defined as a professional charge for a service or product performed or provided by a professional or a facility. So what's usually charged for that service done by that provider. Customary is a range of fees that are typically charged in a geographic area. As we know, cost of living varies in different geographical areas, and so that could also vary the reimbursement rates for those things. So that's why there's a range of fees, and it's specific to a geographic area. Meaning someone like East and West Coast reimbursement rates might be a little bit higher because, the customary might be higher because cost of living is higher in that geographical area. Reasonable is defined as a fee that is justified and relevant to the service or product. So an example would be if you have to have some testing done on some blood, it would be reasonable to also have a phlebotomy charge because you have to have the procedure. So you have to have blood drawn, right? And so that requires equipment, a professional, etc. And so it would be reasonable to have a phlebotomy charge on a blood draw for some, let's say, outpatient lab services. So third-party payers, insurance companies, managed care organizations, and the government are referred to as third-party payers, meaning they're the third party in the healthcare triangle, with the healthcare provider being one of the other ones, and then the patient is the other one. So it used to be just patient-provider. The patient paid a provider for the services way back before insurance existed. When insurances and government programs and all that got added to the equation, we end up with a triangle, and the third party is the payers, the managed care organizations, etc. Fee for service is the preferred method of reimbursement for services. Again, a fee for service is usually where the provider charges a certain fee for that service, and that's what they submit for reimbursements. So historically, the providers set the rate for their services, so they decided how much they wanted to charge for the services, and the government just paid with no questions asked. And this is called a retrospective reimbursement. But this is what increased healthcare costs dramatically because, of course, providers realize, like, oh, well, I can charge a little bit more, they'll still pay it, or I can add this service or this test or this thing, and I'll get more reimbursed. And so it was driving the cost of healthcare up. It's like kind of telling your kids, just buy whatever and I'll pay for it. Yes. So then we went to prospective reimbursement. So this is the most common type of reimbursement that's being used, and it is in the form of a service benefit plan. So this type of prospective reimbursement method was developed and used primarily by managed care organizations. The employer has a contract with a benefit plan. It pays a premium for each of its employees. The employees also pay a portion of the premium to the health plan. The health plan then contracts with certain providers and facilities to provide services to their beneficiaries at a specified rate and makes payments directly to the providers for their services. So they're only allowed to charge like what has been negotiated. So CMS uses a type of prospective payment system within their system. So again, that's why it's probably one of the most used, because CMS uses it, managed care organizations use it. It's just a better way to control costs. So in a managed care organization, the organization reimburses the provider at a capitated rate, which means they receive a set rate for serving enrolled patients, regardless of how much care the provider gives. And remember, that rate was usually like a per member per month to get this amount, and have to manage the population with those dollars, even if they're constantly coming back. So for Medicare hospital reimbursement, in 1982, Congress passed the Tax Equity and Fiscal Responsibility Act and the Social Security Amendments of 1983 to start managing Medicare cost controls. There was a mandate to hospitals for a prospective payment system to establish reimbursement rates for certain conditions, because they had to get this fee-for-service thing was not working. Costs were just skyrocketing, so they said, let's set rates for certain things prospectively, and then this is what we pay. So CMS, so the Center for Medicare and Medicaid Services, in April 2022, they issued their legal requirement to update annual proposed policies for Medicare fee for service for inpatient hospitals and long-term care hospitals. They also publish yearly fee schedules and things like that. So their focus was to build on key priorities to better measure healthcare quality and disparities, and also to improve the safety and quality of maternity care. Because in the U.S., we're not rating really well for maternity care. We're not doing as well as our European counterparts are. So the CMS Hospital Readmission Program, effective in 2013, the Medicare Hospital Readmission Reduction Program was established by the ACA, the Affordable Care Act. It penalizes most acute care hospitals with higher Medicare readmission rates within a 30-day period if it's greater than the national average. So what this means is you have a patient that comes in, for example, let's say for pneumonia, and they are treated at the hospital and deemed to be ready to be sent home, and they're discharged home. If they come back within 30 days with the same condition or worsening of the condition, whether they're readmitted, that's a ding, that's a problem. And so they look at how many patients come back to the hospital or readmitted within 30 days. If you are greater than the national average, then there's a problem in your hospital, and then there's some penalties and some things going on with this. So the excess readmission ratio is based on the treatment of 6 patient conditions. These are the conditions that they monitor. So pneumonia, heart attack, heart failure, chronic obstructive pulmonary disease, which includes like emphysema, so the COPD, right? Chronic bronchitis, etc., and then hip and knee replacements. The penalties are levied across all of the Medicare admissions, not just readmissions. So they're penalized all the way across the board for everything. So it's usually penalized by reduced reimbursements or something like that. Specialty hospitals, such as children's cancer and psychiatric hospitals and rehabilitative hospitals, are exempt from this. And in 2021, the average Medicare hospital readmission rate was 15%. In 2021, so we're going to talk about the CMS Maternal Safety Initiative. So this was as a result of the Biden administration's focus on reducing maternal mortality and morbidity rates. Center for Medicaid and Medicare Services recommended hospitals develop evidence-based patient safety practices for managing obstetric emergencies, along with interventions to address other key contributors to maternal health disparities. So in case you didn't know, there is a big disparity on infant and maternal mortality by region. Certain states are doing not as well as others. Also through race, our African American mothers and infants are dying at a greater rate than the white ones. And so there's definitely a lot that needs to be done. An example of this type of evidence-based patient safety and quality of care is called maternal safety bundles. These evidence-based preventive practices are focused on preventing maternal deaths. So other payment models, the amount of reimbursement is set per discharge of a patient by DRG type. So this is diagnosis-related group, meaning if you come in for this diagnosis, or even if you have multiple ones, like you are expected to the hospital should need this amount of money to care for you, and so that's how much they are going to get. So CMS reimburses hospitals per admission and per diagnosis, which is based on the DRG. So it's a prospective payment system for hospitals that was established through the Social Security Amendments of 1983. They have something similar also for ambulatory care. So the ambulatory patient groups, that was developed in the 1980s. So that was a system of codes that explains the number of services and visits for ambulatory services. Those are your physician, doctor's offices, physician offices, clinic visits, outpatient services, etc. It was adapted into the ambulatory payment categories, So you also have a patient-driven payment model. So this type of prospective payment system is for skilled nursing facilities, so nursing homes. It is used by Medicare and provides for a per diem, that means per day, based on the clinical severity of patients. In 2019, they were using the resource utilization groups. And it was a way of classifying also, skilled nursing facility by how much care and resources they needed. This was changed to this patient-driven payment model because the RUG model was not holistic, and it focused on therapy services, while the PDPM is more interdisciplinary and outcome-driven, so it is better. We also have the home health resource group, so this is kind of its equivalent for home health care, and the patient-driven grouping models. So in 2020, the patient-driven grouping models replaced the home health resource groups with a new case mix classification model. It focused on clinical issues and other patient information to place home health care into more specific categories to have appropriate reimbursement for those services. So in conclusion, for the entirety of the healthcare financing chapter, so as healthcare expenditures continue to increase, the major focus of the healthcare industry is cost control in both public and private sectors, because for years healthcare costs were unchecked. The establishment of the prospective reimbursement systems for Medicare was developed based on care criteria for certain conditions, regardless of provider cost, was an incentive system for providers to manage how they were providing services. So basically, they got put on a budget. This is what happened. And then your new patient-driven payment models, which replace previous models, have improved this type of reimbursement method by focusing on a holistic approach to patient care. The focus is now on efficiency and quality. Also, the CMS Innovation Center's quality payment program models will provide data that support these new effective payment models that tie quality care with reimbursement. The Medicare Hospital Readmission Program is also an attempt to focus the hospitals on quality improvement in their health care. Both the consumer or patient and the physicians concerned were the same, worry about providing quality care while focusing predominantly on cost. The consumer was also worried about loss of freedom of choice of their primary care provider. The physician was worried about loss of income, and in here, to me, this is managed care they're talking about. So these initiatives have focused on providing both quality and cost-effective care. So these are these new payment models. The Patient Protection and Affordable Care Act of 2010, or also known as ACA, and its amendments have focused on primary care as the foundation for the U.S. healthcare system. Many individuals have bought health insurance as a result of the ACA mandate, and the national uninsured rate is 8%, which is very low, which puts us at a 92% healthcare coverage rate. Now, of course, there are a lot of nations that are at 100%. We're not at 100%, but we have definitely made some improvements. So this wraps up our chapter in our videos on healthcare financing, and the next one is going to be on healthcare IT.